We've got a lot of experience at this point on services related to psychiatric rehabilitation. We've been doing supported housing for 30 years, supported education for 30 years. We've been doing family psychoeducation for 35, ACT for 40. You know, we've been doing some things as long as 70 years that relate to the work that we do and that are important. And we've got replications of this in dozens and dozens of countries. We've got research and training, university structures for it, journals. We know a lot about what works in our field and a lot about what doesn't work. And when I say that this is global, I really mean global. I love this example from Ban Ki-moon in 2015. He was one of my favorite Secretary Generals of the UN, and he said, "Everyone is entitled to their hopes and dreams, to work, enjoy family and friends, go about their life without stigma and discrimination, and participate in decisions that affect them. We have the opportunity to raise awareness of the challenges faced by people with mental and psychosocial disabilities and of the efforts needed to ensure that they can lead fulfilling and satisfying lives." We should hire him to run psychiatric rehabilitation services, right? This is a global issue, and I'm so pleased that we're here in Pakistan talking about it. So when we think about distilling the work that we've done over that 70 years, what is it that we've learned? And there are a lot of ways to package and talk about this. We thought that we would give you 4 essential lessons from 70 years of experience that cut across the whole range of programs in psychiatric rehabilitation and recovery services. So I'm going to do the first one, and then Kathy's going to do one, and Scott's going to do one, and I'll do the last one. Number 1. Integrated services work better than segregated services. Now remember, I gave you that long history at the beginning of the day of psychiatric rehabilitation that moved from asylums through recovery services over a period of more than 250 years, right? So that long trajectory. Over that period of time, for the most part, services for people with serious mental illness were delivered exclusively in special segregated settings, right? If you wanted to get services, you went to a special place where only people with mental illness went, and you got services there. And even in psychiatric rehabilitation, for a long time, that was true. You went to halfway houses where there were only people with serious mental illness, or sheltered workshops, or hospitals, or clubhouses. It was pretty segregated. And we know that specialized service settings really can play an important role. You know, they're safe and welcoming. You can set up a special place for people with serious mental illness where only people with mental illness come, and it feels like an okay place for them to be. There's no stigma, people value them, people welcome them, you can have more staff-client interaction easily there. It can be a really good and productive place, but by themselves, these segregated settings don't do as much as we'd want them to do. They don't increase integration in the community. They don't necessarily improve long-term outcomes. They don't maximize client self-management, and they don't optimize long-term quality of life. So they have an important role to play, but we've got to get out of specialized settings and into the community in integrated ways. Let me give you a few examples of what this looks like today in the United States. We used to do housing services only in the United States in very specialized settings like halfway houses and so on. Sometimes people would live there for many years at a time. Over the last decade, we've moved aggressively in the direction of what's called supported housing, or housing first, where the goal is to move the person into housing very rapidly, decent, safe, affordable housing, just like anybody else would live in, with people around them who don't necessarily have mental illness, a regular apartment building, and then move the services over to that person to help them succeed there. So the services go to the person to help them succeed rather than moving them into specialized housing. The amazing thing about this is it works better than housing in specialized settings over the long term. People have higher quality of life, higher levels of satisfaction, better outcomes, and it costs less. So that's an example around housing. We found the same thing around employment. You know, in the United States, we used to have lots of special places where people went for employment kind of training, sheltered workshops, enclaves where you'd have a group of people with mental illness just kind of working together in a special segregated section. And what we discovered is that those didn't actually do a very good job of getting people into the regular workforce. That at the bottom, and you don't need to pay attention to any of what that means except that the tall bars on that are supported employment and the shorter ones are everything else. And in every study that's been done of providing employment in integrated settings with supports to help people succeed in those settings, in every study that's been done across the world now, supported employment worked better than segregated settings. And what we've learned is if you were going to do one thing for a person with a serious mental illness that increased the odds of good long-term outcome, you'd help them get a job. It reduces symptoms, it increases clinical outcomes, it decreases cost. It's just a really good thing to do. So providing jobs for people that are just like anybody else's job, competitive wages, regular settings, and sending the services out to them so they can succeed there works better. Another example around family support. We used to do family support by asking people only to come in for traditional family therapy. And what we've discovered is that if we provide good family support, do outreach to families, give the family support that they need to succeed in their supporting their loved ones, it reduces hospital time, it reduces crises, it improves other outcomes, it improves quality of life, it reduces family burden. Again, moving out into the community and doing services on an integrated basis works better. One more example, supported education. We used to in the United States not even talk about higher education for people with serious mental illness. It's like, well, you have schizophrenia. What do you mean you want to go to the university? You know, today we know better than that. We know that if we have people in regular university settings or technical training or any kind of educational setting, and we have our staff go out to them to help them succeed, to help teach them how to manage in that setting, to help them negotiate with professors around structures that will allow them to get through school well. If we send our staff out to help people succeed in regular educational settings, our clients can do really well. Our clients can succeed there. It works better. So in every place where we've tried this, we've learned that services in integrated settings are superior to services in segregated settings. And again, I don't want that to sound like anything that happens in a segregated setting is bad. I mean, hospitals are what they need to be. You know, places like Recovery House are kind of a segregated setting if that's all it was, but you heard in the presentation about Recovery House this morning all of the work that they're doing to extend their reach and to move Recovery House out of one building and into the community with their outreach programs, their employment programs. We need to be able to do both. But we've got to be able to step away from just segregated settings and move out into the community, into integrated settings. Clients prefer this as well. It reduces stigma. As I said this morning, one of the most powerful things that you can do around reducing stigma is giving people in the community the opportunity to be with somebody with a serious mental illness in a regular role. There's nothing like working in a job next to somebody that has a serious mental illness to learn that serious mental illness isn't that scary and that it's really okay, and to reduce stigma. It increases client satisfaction. It increases clients' engagement in treatment and services. People like it more. They're happier in integrated settings. It increases their ability to contribute to the community. And all of us want to have lives where we do something useful in the world. And there's nothing quite like having a real job or being in a real place in the community where you can play a role and have social standing to contribute to your community and feel good about that. It increases hope for people, and it gives them a real life. And remember, we've talked a few times about recovery as a process of reclaiming your life in the aftermath of a mental illness, a real life like everybody else has, and services and integrated settings work better to do that. So the clear direction of services in the United States has been this kind of an arc, to move from segregated services to integrated services, to move from very specialized settings to generic settings, to move from only professionally managed services to services that also include peers, people who've had their own experience of mental illness as friends and colleagues of our clients, to move from places where there's only staff control to places where there's real partnership and where people with serious mental illness have their own life, and we come to them to support them in partnership and to help their life work better. So that's the first of the major lessons that we wanted to talk about. The arc towards integrated services is really critical, and it's so wonderful to be here and to watch Recovery House moving aggressively in that direction. Okay. Kathy, you want to talk about medical?
So the second thing that we can do is to try and integrate medical and mental health care. They're deeply connected. We know that people with serious mental illness die years earlier than expected. That many of the reasons for that are can be attributed to under-detection and under-treatment of comorbid disorders. We know that people with serious mental illness are at increased risk to have comorbid medical illnesses than the general population. And we know that recovery is only possible if people are alive to take advantage of it. So unfortunately, at this point, we often make people choose arbitrarily what to prioritize instead of integrating care. So we see people in sort of the crossroads, and they can go the mental health way or the physical health way. And often in the case of serious mental illness, any issues related to psychiatric diagnosis prevent people from focusing on any other medical illness that might be present. And this means that people are more likely to have undetected and untreated problems. When care is not integrated, the cost of treating both disorders increases. The outcomes of both decrease in quality. This occurs with depression and anxiety as well as with schizophrenia. So with depression, we see higher A1Cs in people who have depression. We see that people on dialysis with depression are more likely to discontinue it than people without depression. So clearly this is something that we need to focus on. Things would work better if we turned our crossroads around, actually. If this guy just turned around and stayed on one path where both disorders could be addressed, he would have better outcomes. Mental health is improved if somebody's in good physical health, and physical health is improved if somebody's mental health is good. So really keeping yourself healthy as a person is better than trying to focus on one system. The most sensible approach is to prioritize both. And the question is how to do this in people with serious mental illness. And here we have a common failure of care integration. People are less likely to receive standard of care. I've had an experience where I took somebody in for radiation therapy who had breast cancer, and the doctor said, oh, but she has schizophrenia. You know, do you really think that she's going to be able to get radiation treatment? And I said, well, yes, here she is. And in fact, she went every day until she was finished, even though he initially was saying, I'm not going to provide this for her. Common lifestyle factors like smoking and exercise, sedentary lifestyle, we need to address those as well. We need to give people the opportunity to make the kinds of behavioral changes that will improve their health. Another thing that we often overlook is trauma history. And, you know, sometimes we really need to sort of think of what has a person been through and how can we approach them in a way that does not make them more frightened, more anxious, less able to engage with us. So in integrating care, there's not just mental and physical, but we also have lifestyle factors. We found that as far as smoking cessation, 30% of males in Pakistan smoke tobacco, and many more people with schizophrenia. I'm not sure about the Pakistan figures smoke than the general population. But many more people experience secondhand smoke here at work or in social situations. So that's something to consider as well. So providers sometimes make assumptions that symptoms are due to mental illness, even when the evidence suggests that they're medical in nature. And providers may be reluctant to treat even simple medical problems in someone diagnosed with a mental illness. There was a New York Times article a couple years ago that said, you know, this woman went to her physician with an earache and indeed had an ear infection, and he said, I don't feel comfortable prescribing anything. She was bipolar, not with everything else that you're on. And so he sent her home, her eardrum ruptured, and that obviously was not the optimum outcome. So integrated care provides a different framework. We listen to people, we take complaints that could be medical illness seriously. We are proactive. We screen people as you would someone without a serious mental illness. This means looking at mammograms or colonoscopies, any of the preventive treatment that you would do. And we treat problems before they're emergencies. One of the things I think that's a challenge for us as psychiatric providers is to try to link people to medical services. And that's something that's less of a challenge with Recovery House because that's built right in. Okay, Scott?
I'm really happy to talk about this topic because it's one of the things that Bill Anthony instilled upon me when I first met him in 1980. And it's really important to me, and I've seen the effect of hope and client control and the services that I've been fortunate enough to oversee the provision of. Bill told me that hope is an essential ingredient in psychiatric rehabilitation. And I think that in the United States we've moved from this, you will do what I say to recover, to this, will support you for the rest of your life in your recovery process, to this, I want to be your partner in your recovery journey. And I think the evolution of hope has proceeded along that line in the United States. So think about that, this to this to this, as you move forward in your careers and your service. And he also told me the more people are invested in the development of the rehabilitation process, the more successful they'll be in the and succeeding in those plans. And if you tell somebody like this what they need to do, will they resist? I know I certainly did when I was a kid. And in fact, I'm still doing it today. What if you were told in the university that the classes you had to take and there was no question about what those were going to be? Would you be invested in working on something that you didn't choose? So ask questions about what your clients want out of the rehabilitation and recovery process. Use the responses to create a rehabilitation treatment plan with goals stated in the words of persons served. And as a matter of fact, this is one of the standards in CARF accreditation, stating goals in the words of the person served. Understanding you're coming from the client's perspective in terms of crafting a rehabilitation plan that's important to them. I want to try to control my anger. I want to try to get a job. I want to try to get the custody of my kids back. I want to stop smoking. I want to get rid of the voices in my head. So then you take that and you work with the person served and work with the person served to operationalize goals in what we call SMART objectives: specific, measurable, achievable, relevant, and time specific. And make sure that's not something you do in a vacuum, but you're doing it with the person served so they understand the kinds of goals and steps and time that they need to work on those with your support. And suggest possible, prime the pump, suggest possible actions to deal with those goals. And if there are differences of opinion about what those steps should be, Bill told me that you need to kind of merge perspective with the person served and come to some common agreement at what those might be. And then check with the client frequently about the success in meeting those objectives. How do you feel about reaching your objective or goal at this time? Do you think you're learning from this process or learning the skills necessary to reach the goal? And celebrate the client's small successes. Just as we said, celebrate your program successes, celebrate those successes with the client as well. And after achieving the goal, make sure you're asking, well, where do we go from here? And I think that as you move forward in that process and people see that they're actually making steps towards progress, their hope builds and builds and builds. And one of the other things that Bill told me is that not only are people with psychiatric disabilities dealing with the effects of their disability, if you will, but they may be suffering from despair, depression, and hopelessness because they believe they've lost their lives. They have a disability that will never get better. It's the role of the psychiatric rehabilitation specialist to instill that hope and support them and work with them as a partner in feeling that hope on a day-to-day basis. So what you are really doing is really great. You can do this. You can instill hope every day with the people that you serve or will be serving. And congratulations. Remember to congratulate yourself on meeting that goal every day. Tony?
You know, I love those last two sections. There's such important messages in them. Both Scott's, focus on hope and Kathy's, it's hard to recover from mental illness if you're dead. Both of those are really important for us. I want to talk for just a little bit about trusting the research and learning from the research, as well as our own experience in working with people with serious mental illness. So, as I mentioned earlier, historically psychiatric rehabilitation was really a labor of love. It was a matter of faith. We believed that if we had good values and good intentions, that people would get better. We shaped, in the United States at least, a whole raft of political policies and funding streams around that. We really didn't have great research evidence around it, but our values drove political policies that caused psychiatric rehabilitation programs to emerge. We didn't have great ways to teach people how to do psychiatric rehabilitation. You know, people learned how to do this through apprenticeship. If you wanted to learn to do this work, you got a job in a program, and after you'd worked in the program for a while, you kind of picked up how to do it after you had apprenticed. Programs were generally not very well evaluated. There was essentially for a very long time in the field, no real controlled studies of psychiatric rehabilitation. All of the stuff that we knew about it was based on anecdotal experiences. Scott and I go back with the trade association in the United States that would host conferences around this. And you might have 50 or 75 presentations in a conference, and almost every one of them would be, let me tell you about my program and how well it works, but there was no real evaluation. It was kind of show and tell. It was hard because of that to disseminate what we knew and to replicate programs. And so we had really uneven services across the country and uneven effectiveness. It wasn't based on standardized interventions, and it wasn't based on any kind of systematic evaluation. And if you're going to grow a field of study and a field of intervention, you've got to have more than good intentions. But that was the best we had in the beginning of this. You know, it was a brand new mission. We were going to take people with serious mental illness, and instead of putting them in a hospital for a really long time, we were going to give them their lives back in the community. It was new, and that was radical. We had new interventions, things that seemed like they would work well, that made a lot of sense, but they were brand new and untested. We didn't have much experience with it. There was no research. We didn't have a lot of resources to do it. And the infrastructure that you need, that you have in something like traditional medicine, you know, if you're doing oncology in the United States, you've got tremendous training programs. You have research funded all over the country. You have a network in oncology teaching locations in which if you're discovering something, you put it out on the web, and every teaching research hospital doing oncology work will have it that day. There was nothing like that in psychiatric rehabilitation, but we knew that we had to have better services for people with serious mental illness. We knew that they deserved better services. And today that's different. You know, if you go onto Amazon.com and you look at psychosocial rehabilitation or mental illness and recovery or family support, you're going to find hundreds of books on Amazon about this. There are professional journals that are extensive and well respected, things like Psychosocial Rehabilitation Journal and the Journal of Psychosocial Nursing, and they publish every quarter, you know, 8 or 10 articles each, which are peer-reviewed research articles on psychiatric rehabilitation work. We have academic training programs. We have professional certifications, things like clubhouses. You know, we didn't talk about that much, but it's kind of the great-grandfather program in psychiatric rehabilitation. There are now formal certified clubhouses in 34 different countries today. And we have professional associations that help to spread the word. And not just in the United States, we have groups like the World Psychiatric Rehabilitation Association, the International Initiative for Mental Health Leadership. This is a global movement and a global set of resources that are shared that we all can use. It's really different than where we were 20, 30, 40, 50 years ago. We have come a long way. Evidence-based practice is one of the cores to this. and Susan Azrin and Howard Goldman, who have done a lot of work in this area in mental health, have said that employing clinical interventions that research has shown to be effective in helping consumers to recover and achieve their goals is what we mean by evidence-based practices. I like to say that an evidence-based practice is simply the accumulated and the tested wisdom of our growing experience, organizing in a way that we can share it and other providers can use it. Right? That's all we mean by an evidence-based practice. It's a way to give our clients the best that we have, the very best that we know how to do. It's an intervention that is backed by a body of research evidence. There's an expert consensus that this intervention makes sense. There are rigorous research studies that say it actually works. And there are specific client outcomes that we expect to get from this intervention. So for example, with supported employment, there's expert consensus about the best way to do it. We've had dozens of controlled research studies about it that say it works, and the outcomes that we want out of it, client satisfaction, getting jobs, retaining jobs, are very, very clear. There are well-defined interventions with treatment manuals for it, so I can give you a treatment manual to show you how to do it. I can give you video demonstrations of how to do it so that you can do a run at trying to do it yourself. You can replicate this from place to place, and it will look kind of the same from place to place. These interventions have been replicated in a lot of places. Remember, I talked about assertive community treatment earlier, and assertive community treatment has been researched and demonstrated in dozens of countries at this point. So it's been done in lots of different places. And as we do evaluation and as we learn more, we modify the intervention, we evolve it so that it keeps getting better. That's what we mean by evidence-based practice, a systematic way to collect what we know and to distribute in a way so that other people can use it. It's why Recovery House is able to take things that were developed on the other side of the planet and apply them here, because they're laid out in a way that's easy for them to replicate. Now, there's extensive evidence in medicine generally that evidence-based practices are superior to clinical judgment. You know, there have been more than 20,000 medical evidence-based practice articles published in behavioral health for things like cognitive therapy for depression or systematic desensitization for phobias. But there are other things too. You know, standardized practices in anesthesia, standardized practices in diabetes and treatment algorithms for that. Response to stroke, response to heart attack. If you walk into any level 1 emergency room in the United States with symptoms of stroke, they're going to do exactly the same thing, because we know what works best and we've trained people to do it and we replicate that, right? So I will always bet on the evidence-based practice for something, as opposed to a clinician saying, well, I know what the research says, but you know, I think maybe I'm going to do it in my own special way. You know, we've known that for a long time. Mass General Hospital, a very famous case study, there was a study of coronary bypass surgery, and it was the accountants who said coronary bypass surgery costs too much because everybody does it differently, so we're going to standardize it. And I will tell you, the cardiac surgeons were up in arms about this because they all had their way of doing it, and everybody knew that their way was the best. But they got a team together to decide, what did the research say was the best way to do it? And let's all agree what the best way is to do it, and let's standardize it. And not only did it reduce costs, but clinical outcomes were better as well. Betting on the evidence-based practice is always the smart bet. Summary of experience with medical-based practices from Pfeffer and Sutton: physicians trained in evidence-based techniques are better informed than their peers even 15 years after graduating from medical school. Studies also show conclusively that patients receiving the care indicated by evidence-based medicine experience better outcomes. And in psychiatric rehabilitation, we've got a lot of these. You know, the book that's up there, Evidence-Based Mental Health Practice by Bob Drake and others, is kind of the standard text on that. It's available on Amazon and Kindle if you're interested. But family psychoeducation, supported employment, supported housing, all of these kinds of things are evidence-based practices that are manualized, and we've got a shot at being able to replicate easily in other places. A summary of the research on psychiatric rehabilitation and evidence-based practices for people with serious mental illness is really compelling. If we do this work well, we get people working in regular jobs just like everybody else. We improve their physical and mental health. They have friends and family who support them. They live in normal housing. They attend school. They have reduced trips to the emergency room, reduced hospital time. Their health and quality of life is better. They have hope for the future. They reclaim their lives in the aftermath of a major mental illness. Doing these evidence-based practices works. In closing, we want to say a couple of things. Then we've got some room for questions and answers and discussion depending on how long people want to stay and talk shop. And we'll stay here as long as anybody else wants to stay and talk shop. But a couple of things that we wanted to say. We started today saying that being here is a remarkable experience for us. It is remarkable to be in a room with more than 400 people from across many different locations and disciplines and walks of life here in Karachi who are all focused on one thing. How do we build better recovery, psychiatric rehabilitation services for people with the most severe mental illness? And we're here with the staff and the board from Recovery House, really an extraordinary model, pioneers in doing this in Pakistan. And before we go any further, I just want you to give yourselves one more round of applause for amazing, amazing work that you're doing. So this is our consensus advertisement for Recovery House, right? Because we're big fans at this point. Recovery House is a project that deserves to be celebrated. It is a great example of a psychiatric rehabilitation. It is rooted in the values that we've talked about across the day, and it is rooted in evidence-based practice. It is the best of both. The staff are using individualized care to help people recover from serious mental illness. And we really believe that Recovery House, as it expands and grows and gets bigger and better and replicates, can be a model for the rest of the country. Our hope is, that's good. Our hope is that it continues to flourish and that all of you go out of your way, because all of you can do things to help make this a success. Go out of your way to help make this a success as it continues to expand its service offerings and as it continues to move towards its vision of replicating and doing more of this. We think that Recovery House and its spin-offs are really going to be the lifelong learning laboratories for the entire country when it comes to psychiatric rehabilitation. And all of you here supporting the mission of Recovery House and supporting each other in moving through this, we really believe that if we came back here in 2 years, 5 years, 10 years, that we're going to continue to be amazed by the progress that you make. It really has been an extraordinary time being here, and I'm so humbled by all of your efforts and so proud to be here with you.